Sanjeev Arora, and I'm a gastroenterologist by profession and a professor at the University of New Mexico, and I serve as the director of the ECHO Institute at in the United States at the University of New Mexico. Over to you, Soumya. Can you introduce yourself?
Sure. My name is Soumya Swaminathan. I'm a pediatrician by training. I'm from India, and I spent most of my life in India working on tuberculosis and HIV research, and then as head of the Indian Council of Medical Research before I moved to the World Health Organization, where I'm currently the chief scientist of the organization. And this is the first position, I'm the first incumbent of the position of the chief scientist since March 2019. Thank you.
Naveen, over to you.
Thank you, Sanjeev. Thank you, Soumya. It's a pleasure. Good morning, good afternoon, good evening. My name is Naveen Rao. I'm the Senior Vice President at Rockefeller Foundation, in charge of all the health grants. I'm an internist by training, and I'm really excited and looking forward to a good panel discussion today. Over.
Okay. Over to you. I think you're next, Naveen.
Yes. So thank you very much. I really appreciate it. As I said, looking forward to a good discussion today. Basically, first I want to start out by thanking Catalyst 2030 for hosting this important conversation. Catalyst 2030 was founded through the collaboration of the Schwab Foundation, Skoll Foundation, Ashoka, and Echoing Green. It's a movement to bring together multi-sectorial stakeholders to tackle the most complex social challenges and achieve SDG 3. So with that, I'd like to open it up, and the topic of today's panel discussion is about reducing disparities and democratizing healthcare. If I were to look at it as an introduction from the position that I hold at Rockefeller Foundation, I see three challenges, and I just want to lay out the three challenges so that when we get to the panel discussions, we can be pointed and specific about how can we overcome such challenges. So the first challenge is about health disparities. Even prior to COVID-19, we were witnessing huge health disparities and inequities throughout the world. Millions of people around the world face persistent socioeconomic barriers that impact their well-being and their health. This inequity is driven at a basic level by unequal access to essential health services, as people are cut off or unable to regularly receive affordable quality care. The way I'm looking at it is good health seems to be nothing more than a result of winning the birth lottery. There's a very good chance those of us on this panel today listening probably enjoy good health, and it is just because we won the birth lottery. We were born in the right country, on the right side of the tracks, at the right socioeconomic, and we enjoy good health. Today, life expectancy in many places is directly linked to the zip code. And it shouldn't be like that. Health shouldn't be the result of a birth lottery. And so that is the first challenge. The second challenge is in terms of the class divides of the haves and the have-nots. Today, if the class divide, as I see it, seems to be money. They're the haves and the have-nots, and again, those who have money have good health, and those who don't have money don't have such good health. And I predict that the class divide of the future will be access to data. And again, if you're not careful, this divide will increase, and those who have access to data will have better health than those who do not. Second challenge. And the third challenge is, of course, COVID. We have not felt the full impact of COVID. There is still a lot ahead of us, but we know this much, that COVID has ripped open the covers and shown systemic disparities and inequities in all policies and in all effects. So who the COVID is affecting more, who is being hurt the most, all this again comes back to disparities and inequities. So if this is the challenge, the opportunity, of course, is that we deal with this crisis and build something better and stronger out of it. And so the question is, can we build back stronger, more inclusively, sustainably, and resiliently? This opportunity is being called the Great Reset by Klaus Schwab at the World Economic Forum. And today I want to talk about reducing health disparities and achieving democratizing access to healthcare. Those are the twin topics. We are joined by two eminent, well-qualified experts in the field who have introduced themselves. Personally know them and respect them, and I'm really looking forward to some insightful conversations. So to kick us off, I want to ask Sanjeev the first question. And specifically, Sanjeev, can you talk to us about these barriers that lead to health disparities? And how specifically can we bring down these barriers and reduce health disparities? What have you found to be the most effective solutions, very specifically?
Thank you, Naveen. I think a very simplistic way, Naveen, to think of these barriers has been there's just not enough money, that there's too much poverty, and that, of course, leads to all these barriers. And I would like to submit that, it's much more complex than that. It's not just a lack of money. Certainly, that is one cause. But there is so many barriers that can be overcome without a lot of additional resources through imagination, through technology. For example, 1.6 million people die of tuberculosis every year. 1,100 in India, even though the medicines are free, they're available, the diagnostic tests are there. 1,800 children die every year of diarrheal diseases. I mean, every single day. 1,800 children die every single day of diarrheal diseases, when we know that oral hydration and some simple antibiotics could be very helpful. And so the question really that came to my mind was, if we just democratize knowledge, even without taking extra money, could we actually make a big difference? And I saw this in my own practice, Naveen, at the University of New Mexico in the US, that I saw this 43-year-old woman, and she came to see me in around 2001 and said, I have hepatitis C. And I said, how long have you had it? And she said, I have had it for 8 years. So I said, why did you not come earlier? And she mentioned to me that, she would have to travel 200 miles each way to see me because there were no specialists in her rural town. And I said, why did you come today? And she said, I came today because I'm having pain in my right upper abdomen. And I did an ultrasound, found she had a liver cancer. It was too late. And she left two children, a 9-year-old girl and 14-year-old boy, and passed away 6 months later. And I was asking myself, why did she die when every resource was available? All the tests were available, all the money was available. And the answer came that she died because the right knowledge didn't exist at the right place at the right time. And so that's why I started ECHO to solve that problem. ECHO is a model to democratize knowledge, and it's a scalable platform to implement best practices. So in New Mexico, the problem was there were 28,000 of these hepatitis C patients, and my wait was 8 months long. Less than 1,500 had been treated. So we started 21 new centers of excellence for treating hepatitis C in these rural communities. And each center was run by a primary care clinician. We shared our protocols, and once a week we would get together with them, just like I'm getting together with you, Naveen, and all of the other attendees. We would get together and discuss cases in a de-identified way. And soon they had become experts. And in about 18 months, the wait in my clinic fell to 2 weeks. Tens of thousands of patients got treatment. And at that point, we knew we had a model that could be used all over the world for many diverse diseases. And sort of it's an all teach, all learn model. It works like this. Teams of experts at a regional medical center called hubs use one-to-many video conferencing to engage with local health providers in weekly ongoing knowledge sharing, case-based learning, telementoring. And these hub and spokes learn from each other, and everyone's knowledge is increasing. So currently we have hubs in 41 countries. We have 425 hubs. We have learners in 158 countries. We do ECHO for more than 70 different disease areas. And of course, we had to demonstrate, and we have 275 publications showing that the care that these rural providers in prisons and rural areas can be as good as universities. But about 6 months ago, the whole world changed for us. We knew that COVID-19 was the big problem of of this century. And we started using ECHO for COVID-19. And so far, we have trained more than 600,000 healthcare professionals all over the world in COVID-19 response, and in very diverse things like how to do testing, how to set up a testing program, how much anticoagulation to do, what kind of ventilator do you need, how much oxygen should you give, and so on and so forth. And more in the future, we have plans to use this for vaccination. So at least we have found one way that even without having extra money, just by democratizing knowledge and expertise and putting in an all teach, all learn framework, we can have a huge impact in countries all over the world. Thank you, Naveen.
Thank you, Sanjeev. I have some follow-up questions, but before I get there, I would like to invite all the attendees, and there's quite a few on this call, to put in your questions into the chat. We'll get to your questions and answers. I'm hoping you will have some pointed questions that will allow the speakers to bring out what is best, which is from their experience. Now, I would like to turn to Dr. Swaminathan, and then I'll come back. Sanjeev, I have some questions, but I'd also like to see what the audience brings up. Thank you very much, Sanjeev. That was very well articulated. Dr. Swaminathan, as the chief scientist at the World Health Organization, you know more than anybody else all too well how these disparities exist around the world and how they affect health. So the question to you is, from your point of view, what are the most effective strategies for reducing these disparities? Specifically, today's topic seems to be how can we democratize access to healthcare in our lifetime? Do you really think we can do it?
Thank you, Naveen. And I think I agree with what Sanjeev was saying. And I have seen myself the power of digital platforms, including the ECHO platform, in reaching those places and those communities where specialists do not exist. So from my own experience in India, I saw that for the management of multi-drug resistant TB, for example, that used to be done only in few specialized centers. Patients would have to travel hundreds of kilometers and get admitted in a hospital and lose their livelihoods, be away from families, really very disruptive. And that's one of the reasons I think why patients do not access care at the timely manner, is because of these kind of practical difficulties. And so platforms like ECHO that can be used both to do provider-to-provider training, but also to do telemedicine. I was traveling in a very remote part of North India in the Spiti Valley, which is cut off from the mainland for 6 months of the year because of snow, because the pass is cut off. And people living in that village do not have access, except for the local primary healthcare center and the local district hospital, to any specialized services. But then I saw that they had set up telemedicine services. They were actually connected with a hospital in South India, where people speak completely different language, but there were specialists over there who could provide services to people in this remote village. So certainly digital technologies, if leveraged, can really start bridging these disparities. But I think we also have to be very careful in ensuring that we don't have a system where there are people who are digitally excluded. So we have in every society, of course, those who are left out of many services. They are usually the poorest, the most vulnerable. They may be minorities in terms of race or ethnicity or other population groups. And or they may be migrants, they're moving from one place to another. They often get excluded. And these may be the same groups who do not have access to mobile phones, or at least to smartphones, or access to internet that we all take for granted. And so I think both in the fields of health and education, we have to be extremely conscious of the fact that while technology is really going to help us to make huge leaps and cover a lot of ground, we we need to make sure that we're not, again, leaving some people behind. And of course, for us, the SDG goal of leaving no one behind is extremely important. Now, the pandemic has, in fact, fast-tracked some of these developments. Countries which would otherwise have taken some more time have really moved very rapidly ahead in trying to expand their digital footprint. Many countries are now coming up with digital health policies. The WHO has a global strategy for digital health, which is going to go to the World Health Assembly for approval. It should have happened in May, but hopefully it will happen in November. This sort of lays out a roadmap for what countries need to do. And this applies to high income as well as middle and low income countries, because in high income countries, there's the opposite problem of the lack of interoperability and the fragmentation of systems. Nothing talks to anything else. And so it doesn't really help the patient in the long run. And so there also systems really need to be restructured. The final point I'd like to make is about data, and you mentioned that, Naveen. Without data, good data, it's impossible for governments to take action because unless you know the disease burden in the community, unless you know what the major causes of both mortality and morbidity are, it's very difficult to channel resources. And so for a long time, I think it is believed that in low and middle income settings, infectious diseases and maternal and child health problems are the major causes of mortality. In the MDG era, this was true, but a lot of, as you know very well, a lot of advances happened during the MDG era in maternal and child health, but gradually and imperceptibly, the burden of non-communicable diseases was growing, and it was not really detected. It was not picked up. Today, we are in a situation where we have 10% of the world's adult population being hypertensive, with only a small percentage of them actually knowing and taking treatment. And the preventable deaths to what we call premature mortality due to non-communicable diseases is much, much higher in the low-income countries than it is in high-income countries. Probably for the reason that the diagnosis and management, even though these are quite simple, low-cost, affordable, they're not available. And that's because data is not being collected. So governments need to invest in data collection systems, in civil registration and vital statistics, what we call CRVS, birth and death, not just birth and death registration, which is essential, but also the recording of the medical causes of death properly and systematically, so that actually feeds back. And again, how we can collectively, the private sector, the public sector, work, empowering citizens also, because it's a question of data. And data, of course, is something that we can debate who owns data, who owns your health data, etc. But there needs to be a discussion around the ethics and the social and the legal implications of that. But eventually, certain critical elements of data are absolutely essential for governments and policymakers. And so the public needs to understand and appreciate why they may be giving up their health data or certain parts of their health data for use in planning and therefore improving health service delivery. Over.
So thank you, Soumya. I have one question for you and one for Sanjeev, and then we'll open it up. There's a ton of questions coming in on the chat, which is good news. That it means everyone's paying attention and listening, and I really appreciate all the comments you made. Just as an extension to one of the comments you made, which is probably the last one, is about who owns the data and health privacy, security. It seems like everyone is guarding their data, and data has become the new oil. It has become the new leverage. And if that is the case, how does WHO approach this criticism that you still are dealing with the FENSA, non-state actors? The private sector seems to have a lot of the data, and you have made a lot of outreach, and you're working with the tech companies and private sector. But one of the things is we're still locked into this public health versus private health. And how is the WHO reaching across the fence to work with the private sector?
Yeah, thank you for that question, Naveen, because I think we've made huge progress. And the WHO of today is very different, I think, from what it was. The FENSA that you mentioned is basically a framework for engagement of what we call non-state actors, which are NGOs, civil society organizations, basically those who are not government. And because we are a member state driven organization, we are governed by our 194 member states. And the other important point is that we're a normative agency. We're one of the few UN agencies which is a normative, which means that we make guidelines and we set standards. And therefore, we have to have policies around conflict of interest, which ensure that the work that we do and the norms and standards that we create are free from any sort of conflicts of interest. And that is why, you know, we have these rules of engagement. But having said that, within the framework of FENSA, we are able to engage widely with private sector, whether it is companies that are marketing food, working with them so that they voluntarily adopt some of the good nutrition practices like reducing trans fats or reducing salt and sugar, or whether it's working with digital tech companies, which we've done a lot in the last few months, both to reduce misinformation and make sure the right information is available to people who are searching for it, but also to provide solutions that for countries that are facing problems, especially given the context of the pandemic. So we found ways of working. The one thing that you mentioned, which is that most of the data is currently in the hands of the private sector, is true. And I think we need to really have that dialogue about what is, again, a global public good. The kind of data that's being collected by the tech companies, some of it is health, a lot of it is not health related, but is very relevant for health. Could that be leveraged in some way? And there are now initiatives looking at how we can use global data and use artificial intelligence and machine learning on those big data sets to, again, to provide solutions that would be considered global public health goods. And this needs a dialogue between the private sector, tech companies, member states, the public at large, and multilateral organizations. And I think the UN Secretary General himself has been, I think, very much for this kind of digital cooperation, you know, as was laid out in his report last year. But this is an area which is ripe to tackle. I think now is the right time.
Now is the right time, and you're the right person, Swami. I really tip my hat for being in the target of everyone and yet continuing to do the right thing. So my congratulations and support for WHO. You're on the right track. Sanjeev, coming back to you, a pointed question for you. While telemedicine will take care of all the overcome the barriers, and I really appreciate your right knowledge at the right time, right place concept is so poignant. But there are still barriers that exist for good health that telemedicine will not take care of. And so I'd love to hear from you specifically, for example, behavior change messaging. How do you make sure that they actually take the medicine? How do you make sure that we're talking about the social determinants of health? How can we make sure that today we are not just caught into the old paradigm of medicalizing health, and that health is both health and healthcare, and healthcare is hospitals, doctors, and medicine, which is what we focus on. But there's the whole health component and the social determinants. And how does your program, ECHO, deal with the social determinants, the holistic nature? There were some of the questions that came up had to do with that.
Thank you, Naveen. I think that the first point I wanted to make is that what ECHO is not traditional telemedicine where one doctor takes care of a patient. It's much more of a capacity building model where one to many, 25, 30 doctors, nurses are trained to build their capacity. It's sort of the difference between giving somebody a fish, which is telemedicine, or teaching them to fish, which is ECHO. Both are highly effective. But let's take the example of an area, Naveen, that is so familiar. You are a world expert in this area. That is this issue of reducing maternal mortality. I mean, you worked in this area for a very long time. We know that a lot of mothers in the world die unnecessarily, either because of infection or high blood pressure that didn't get treated, or obstructed labor or excessive blood losses. And there are so many different causes. And when I look at that list, I realize that if we really had used the available technology to do training and mentoring of local healthcare providers without a lot of extra money, we could save many lives. So that's one key idea that I want to make about ECHO. The second is, we don't want the perfect to be the enemy of the good. That is, just taking knowledge there is not going to create perfection, because sometimes you need other resources, sometimes, but it can make a huge difference. And the last part that you talked about, the social determinants. One of the challenges is that, as you said, there is adherence problems. In fact, even in the United States, a developed nation, recently, 3 weeks ago, a survey was done, and only 2/3 of the people of the United States said that they would be willing to take a COVID-19 vaccine if it was available. So there is vaccine hesitancy, which will become a major issue for the world because we have never vaccinated a whole planet together. So by getting the right knowledge at the right place at the right time in the right hands is so critical. That means it is not that a university specialist is telling you, you need to take the vaccine, or telling a woman you need to take the HPV vaccination. It's their local community health worker with whom they have a relationship, who really teaches them about diet and exercise and the need for an HPV vaccination and all of these very basic things that are required. Without that, it's going to be very difficult to tackle the social determinants of disease without having local, highly empowered individuals who are trusted in their community, who can speak the same language and talk about the benefits and risks. And the way I like to describe it, Naveen, for the oncoming problem for which we plan to use ECHO, that is training millions of workers on the vaccine, is in order to deliver a vaccine for COVID-19 to someone in Africa, you have to have many conversations. How will it help them? How will it help their family? What are the side effects going to be? What is the downside? If they're getting side effects, who will treat them? Who will be trained on giving that vaccine? How should you build the cold supply chain? And there is so much that can be tackled with knowledge, but yet it will not be perfect. We still need to democratize wealth in addition to democratizing knowledge. But that is a lot harder because democratizing wealth, Naveen, is a zero-sum game. Whereas when you democratize your knowledge in an all teach, all learn platform, everybody becomes richer. I call it the physics of knowledge is different. So to start a sharing economy, let's start with knowledge.
Wow. Yes, going back to my own Indian roots, it's that from one light you can light another lamp, and it doesn't take away from the light of the lamp that you used to light the other one. So it's not a zero-sum game for sure, Sanjeev. But let me ask you, how are you getting feedback through your model, ECHO, which seems to be knowledge flowing one way? How are you getting knowledge flowing back the other way to make locally relevant decisions? Because vaccine hesitancy in certain parts of certain communities in the United States may be different than what is driving vaccine hesitancy in say, in Africa or India. So how is knowledge flowing the other way in your system? Can you talk to us about that?
Yeah, in a traditional ECHO model, Naveen, we have a rule. The experts can only talk about 50% or less of the time. They're not even allowed to talk more than that. Sometimes we break that rule inadvertently, like we did this morning. But the thing is that every ECHO is a needs assessment. That means the core principle of ECHO, Naveen, is all teach, all learn. The specialists have to learn from the provider. So when I have 30 primary care clinicians learning from me, I am bringing the domain knowledge, and they are bringing the barriers to implementation, the social, cultural circumstances, the economic barriers, the resource constraints, and together we create new solutions, which are culturally appropriate, resource appropriate, etc. But yes, we would call it a failed ECHO clinic if the experts spent all the time disseminating their knowledge.
So great. I'm really appreciative, and I'm having more and more respect for the project because you really seems to have thought through all these issues. Coming back to you, Dr. Swaminathan, one of the issues that is floating around is the ripple effect of this COVID, and that while all our attention and the world's attention right now is on this pandemic, and rightly so because it's raging right now. But the knockoff, what they're calling the lockdown mortality, deaths and morbidity and mortality that have increased in TB, HIV, malaria, child deaths, neonatal deaths. I mean, everything seems to have taken a setback, and some people are saying we've gone back 2 decades. We are where we were on some of these measures. And so while the attention is on COVID, and I know WHO is focused on it, and you have biweekly, and you're having regular press briefings, but who is talking and who is keeping the light on and focus on the lack of essential healthcare services and the ripple effects and the deaths that are happening because of that? I know you're focused on that, Soumya, but I'd like you to talk to this audience about how WHO is keeping its attention on the essential health services beyond COVID.
Yeah, I think that's a really good point. And the fact is that almost again, all countries ranging from high income to low income found themselves taken by surprise and were overwhelmed. Their health systems were overwhelmed when this actually hit them. And it sort of tells us also that the metrics we were using to assess pandemic preparedness, because as you know, there are metrics and there are surveys that are done. And there's even a rating of countries, the Global Health Security Index that had been done. And in fact, the countries at the top of the rating were, like some of the high income countries, were actually the ones which ended up having high mortality and were unable to control transmission. So it brings back the point that we need to invest much more in public health. And as Dr. Tedros keeps talking about universal health coverage, for the last 3 years, WHO has been asking political leaders to make commitments on expanding universal health coverage, which is not just the provision of health services, but also the kind of policies and laws and regulations you need to address the social determinants of health and to address risk factors like tobacco and alcohol, but also high salt and sugar in the diet, air pollution, water sanitation, road safety, mental health. These are things we've been talking about for several years now, and saying we need to invest much more in this and ensure that there's financial protection, at least for everyone in the population, so that they don't have to pay for these. And a lot of them are services, but as I said, a lot are outside the health sector and therefore need stewardship and advocacy from health sector, but not, the action is in other sectors. Now, I think this pandemic exposed all those weaknesses, exposed the fact that we haven't invested in public health enough. Most countries do not have a vibrant public health cadre that could easily respond to this kind of thing. Lab infrastructure, surveillance, at the decentralized level, human resources, enough people who understand epidemiology and so on, who can go and do the outbreak investigation and response. So the detection, the prevention, and the response to outbreaks is something that needs to be built in along with the provision of universal health care services. And that's not something that has been done. So the first lesson, I think, is, and the Global Preparedness Monitoring Board report that came out this week, which is called A World in Disorder, builds on the report that they submitted last year at the time of the UN General Assembly, which basically had warned that a pandemic would sooner or later come to the world and that we were unprepared. So last year they said a world unprepared. This year they've said a world in disorder. And they've outlined what the key actions are, starting, of course, with political commitment but also engaging and empowering citizens. So I think it's clear that this is not going to be the last pandemic or the last big infectious disease that we're going to see, new one. So looking ahead, I think health systems need to be prepared to deliver all their essential health services and be able to do all the things that we are now having to do. And the way most countries are doing it now is by diverting all their resources into the COVID response, thereby having the kind of impact you just mentioned on TB, on maternal and child health. A survey that we did showed that 90% of about 100 countries responded, 90% said that their essential health services had been significantly impacted. In the case of immunization services, up to 80% of countries said that they were severely impacted. So it's a question of human resources, but also all the other enabling functions that a health system needs in order to tackle it. So that is where we need to now start putting our efforts and building up the systems. And I think the data system is very integral part of the capacity to be able to respond. But in many cases, it is also about, you may have people there, but then you have to build their capacity. So that is again where the training and mentoring, ongoing mentoring is really important.
And that is really absolutely aligned with the Great Reset about inclusivity, sustainability, and resilience. So it is in the right track, and mentoring and training and knowledge continues to come up. And so Sanjeev, my question to you based on that comment is, how prepared do you think we are as a world that if another pandemic came down our way, we would be better off than we were? Or do you still see us exactly as unorganized as Samya mentioned? And what role could ECHO play in making sure we are more prepared? And how do you use artificial intelligence? How are you using data analytic tools? Talk to us a bit more about just beyond telemedicine that is an opportunity for you.
Yeah, Naveen. So one of the biggest challenges I see is that let's take the COVID-19 pandemic. It's a global pandemic, and the virus does not respect any national boundaries. We've taken a globe and we've drawn some artificial lines. The virus can't see them, so it spreads whereas the response to the COVID-19 virus in the world is a national responses. There's an imbalance. There needs to be collaboration, much greater collaboration between countries of the world. And in order for us to really make this work effectively. And for example, what we are doing, and if you allow me this privilege, I happen to see two of my colleagues on. One is Dr. Bruce Struminger, who leads our work in Africa for ECHO, and Leonard Bikenezi, who is on the ground in Africa. And I think rather than me describing our vision, maybe he can tell you how we partnered with WHO Afro and Africa CDC on global health security. And so first you, Bruce, and then Leonard, if you can make a couple of comments briefly, I'd love to hear from both of you. Yeah, go ahead, Bruce.
Thanks, Sanjeev, and wonderful to have this opportunity. I think the opportunity and what we've seen over the last couple of years working with Africa CDC for about 3 years to help them set up their regional networks, which did allow them to rapidly respond, at least through communication, in these multi-country networks that they've been running for 3 years now, focused on cholera, focused on Ebola, focused on Rift Valley fever, mostly regional issues, but being able to use the power of this medium to collaborate and share information, on a weekly basis, just in time, and to have those networks already up and running when a pandemic like this happens, and will happen again in the future. As a colleague once told me, a public health emergency is not when you want to be handing out your calling card. You ideally already know your colleagues in the region or across the continent or globally to be able to collaborate between regions. So I think we've seen these efforts exponentially accelerating and working with WHO Afro since March, helping them use this type of platform to connect all 47 countries in the Afro region, to connect clinicians on the ground, Ministry of Health, senior officials, implementing partners, to bring all of them into the conversation, to have these real-time opportunities to collaboratively problem solve and to disseminate information and have the information moving in all directions. So I think that, you know, we're building on these and there's a major acceleration of using these tools now, and also with other partners like the African Society of Laboratory Medicine, the Infection Control Africa Network. They've been building these multi-country networks for a couple of years, and I think it's helped them quite a bit. But maybe Leonard, you've had a wonderful perspective in Namibia as the chief mentor for the HIV program for the Ministry of Health, running the HIV ECHO program there and leveraging that program to rapidly pivot to support the Namibian COVID-19 response.
Yes, thanks, Bruce, and thanks, Sanjeev, for that. So I think just following up on the discussion and just giving some perspective, especially from Namibia as an African country and the first country in Africa to adopt and adapt this ECHO model in 2015. I think there are a couple of lessons we learned. I think number one, just lesson from our HIV program is that funding is very important, and most African countries are getting funding, especially through PEPFAR, but also not only funding, but a good collaboration with different implementation partners as well as non-government organizations is key as well. Leadership is key, especially in Africa. The buying-in of leadership is key, especially for such models and if you want to democratize knowledge. But for Namibia, what we did is we're sort of in I call it a hybrid model where we have the clinical mentoring program, where we've got clinical mentors who are basically moving from one facility to another, trying to reach as many healthcare workers as possible. And then we supplement that with the telementoring program using the ECHO model. And when we combine these two, we were able to reach many parts of the country. Namibia is one of the countries with a very low population density, so the distances are huge. And this really is affects a lot of our patients. And not only our patients, but in terms of expertise, in terms of our healthcare workers as well, we don't have a lot of experts. But when we use this telementoring program using the ECHO model and the clinical mentorship program, we're able to not only reach healthcare workers, but to sort of standardize the care that we're giving. Because as much as we've got very good WHO guidelines on HIV, if they don't reach the end users, they are not good. But with the ECHO model, we're able to do that. We're able to reach all healthcare workers and ensure they are providing high quality care. As a result, you can see that countries like Namibia, who are in Africa, countries like Uganda, Eswatini, who are starting to implement this model, can also have high, good data. I was just looking at the New England Journal of Medicine of 2019 March, which highlighted that Namibia was one of the countries which has very good viral suppression compared to even other countries like the US and other developed countries. So you can see that really when this model is applied appropriately, and of course other modalities as well, it's possible to provide high care. And not only that, it's also possible to get good results. And because of that knowledge and lessons we learned, we're able to use it for our COVID response. So early on, we were able to leverage it and start using it for training, mentorship on COVID. And as a result, we're sort of ahead of the curve when compared to other African countries when it comes to COVID-19 pandemic. Thank you.
So thank you, Bruce. Thank you, Leonard. Always great to hear real life on the ground from the field insights, because the rest of us are sitting in air conditioning and you're the real heroes on the ground doing the work. So I really appreciate that. And thank you, Sanjeev, for offering those insights. We're coming to the close, but I just do want to make sure the audience hears from the panelists. There've been a lot of good questions on the chat. There are a lot of links. A lot of people have offered to continue to work with WHO and with ECHO. So I'm presuming the organizers will take heed of that and follow up appropriately. But I'd like to take this a little more personally. Soumya, you're doing a great job. And really, as I said, I can only imagine your to-do list every day when you wake up. But what keeps you up at night? What concerns you the most of all the things that are on your plate right now? What keeps you up at night, and how are you dealing with it?
I would say a couple of things. The first one being that, as the chief scientist of the organization, I have to be on top of all the advances that are happening. And we've learned so much in the last 8 months. I must say, the one big positive for me in this pandemic has been the global collaboration and the openness, the willingness to work together that we've seen from doctors, healthcare workers, scientists, academics, researchers from around the world from day one. And that's the reason why we've been able to really advance our understanding about the virus and also how to control it eventually, including therapeutics, vaccines. And as you know, we had the Global Research Forum in February. We followed that up in July. We've got huge networks that we work with. So WHO does its work essentially because experts around the world are willing to give their time and their knowledge. And that's a huge, huge plus point, sitting in WHO. You can get the best people, just make a phone call. That's our strength, our convening power. But what really worries me, and where we've put a lot of mechanisms in place, is to make sure that we are actually leveraging that huge amount of knowledge that's being generated on a daily basis. Some days the team is looking at 400 to 500 publications and preprints in a day, and from that picking the ones that are the high quality ones, making sure that it goes into a pooled analysis, that we are updating our reviews. We do rapid reviews every week to update every topic and update our guidance on based on that evidence. And of course, we are working with a number of groups around the world to do that. We could not have done this alone, but that responsibility of making sure the right information and knowledge is going out to the world, both to the lay public as well as to healthcare providers and scientists. That's one of the key things that's always on my mind, and how can we do better and better? And it relates very much to our ongoing quest in the science department to make quality assurance an integral part of, and use the latest methodologies and benchmarks to make sure that whatever we put out is not only scientifically excellent and relevant, but also timely in a format that's user-friendly and quickly implementable and responding to user needs. The second thing, of course, that worries me, like I'm sure worries everyone, all of us and people around the world, is the impact that this pandemic is going to have on people's lives and livelihoods, and the fact that we're going to see increasing poverty, increasing undernutrition and hunger, and perhaps increase in many of the other diseases that we mentioned. And we really need to start thinking of ways of mitigating that impact. And yeah, I mean, I think inequities have worsened, and that's really very tragic to see how the existing inequities in society have been made worse by this pandemic. And I think it's using some of these tools that we can try to address that, but it will require a huge effort, and we have to work together on that, private sector, public sector, and ordinary citizens.
Well, Soumya, I know I put you on the spot there, but it's really heartening to hear that these things concern you, and really the world needs to go to a better place. So I'm glad at least you're identifying it and you're working on it. So Sanjeev, coming to you to close this down, talking about huge efforts and what Soumya just said about multi-sectorial collaboration, could you give us an example of a hurdle you faced on the ground, Sanjeev, even earlier on or even now, that continues to come up, even though you feel you've overcome it, that is the one thing that continues to hold you back?
I think, Naveen, what keeps me up at night and the hurdle and the difficult problems are the fact that 6 billion people in the world don't have the right knowledge at the right place at the right time. Millions die unnecessarily. Now, as you're from India, you mentioned, the goal of life being ever conscious, ever present, never new bliss. I can tell you that we cannot in this world reach a state of peace and joy with this much inequity. This much inequity is the root cause of a lot of terrorism, wars, famines, all kinds of problems. And the hurdle that I see is that the dominant paradigm for knowledge in the world is knowledge monopolization. Because knowledge is power, knowledge is money, knowledge is fame. But as you say, you can light one lamp, you can light 1,000 lamps with one lamp without diminishing the glow of your lamp, right? So the question then is, how do we overcome this fundamental way that we actually reimagine the role of an expert in the world? That reimagination means that, yes, of course, I can use my knowledge, my fellowship training as a GI doctor to make a good living. But I also have another responsibility to the world, and that is to share it and mentor other people to be as good as me. And I think that idea of people sharing, and I'll give you an example of what we did this morning. It so happened, so we have a global collaborative series, which also Soumya Swaminathan moderates from 8 to 9:30 this morning, Mountain Time. We had a session where we had Director General of COVID-19 response for CDC in China. Soumya was moderating, people from South Africa, from Europe, from different parts of the world, world experts talking to each other and sharing knowledge. And so I guess my main hurdle I see is that so much can be done in the world just by sharing and collaborating, that we need to do that now to prevent these global catastrophes that are happening with millions of unnecessary deaths, and then the consequential changes on our society and the suffering and the terrorism that exists as a result of that.
So you're definitely walking the talk about being the change you want to see in the world. So I really tip my hat. We've come to the end of it. I really hope the audience appreciated the fact that you had two world leaders talk to us about their professional and their personal concerns and hopes and aspirations. And at the end of the day, I'm walking out with a sense that there is optimism, that there is a way to get around this. And as a humanity, we need to come together to survive. It's come down to that. But I hope you've all enjoyed it. The chat will be moderated and taken into account and follow-ups there. But just in closing, so that I do allow the panelists to say anything that they still feel. I mean, we've got 2 minutes left. So they say a good meeting is the one that ends on time also. So I really hope all of you enjoyed it. But just before closing, I would like to first ask Soumya, as a closing comment, if there's anything she'd like to leave the audience, and then the same with Sanjeev. And so really appreciate it. Soumya, anything you feel as parting wisdom? There's somebody who's not on mute. Yeah, thank you. So Soumya, please.
Well, I think that, yeah, it's given us an opportunity for all of us to introspect, I think, and to really look at priorities and maybe to think about, what we've done to nature and environment and so on as well. We tend to think, as medical doctors, everyone lives in their own worlds and in their silos, and we're realizing the interconnectedness of animal kingdom, human beings, and the environment in which we live, and the practices that we have adopted, which have resulted in many of the things that we're seeing, of course, infectious disease outbreaks, but also things like the air pollution and the destruction of the environment, just the impact of climate change. And we know that the pandemic came very suddenly, very acute. Hopefully we'll come out of it in the next couple of years because of science and the technologies that we have. But climate change, we know, is going to be there. It's not going away. It's inexorably increasing and advancing unless we do something about it. So we talk about global solidarity in addressing the pandemic. We also need global solidarity to address some of the other big threats, which I guess are also related to this, the Great Reset and the way in which we're going to solve these global problems. It can't be done country by country. It can only be done by global solidarity.
Wow. So poignant. Really appreciate that, Soumya. Sanjeev, over to you for the last word. What would you like to leave the audience as we exit today?
You know, I'm not as eloquent as Soumya, so I'll just end with two quotes which summarize what I want to say. One is a quote from Nobel Prize winner Albert Schweitzer, who was a physician, worked in Africa, and he said, "I don't know what your destiny will be, but one thing I do know, the only ones among you who will be really happy are those who have sought and found how to serve." And I think in order to make the world better, we all need to reflect on this statement and see, do we really want to be happy, and how can we serve? And the second quote I want to say is from Margaret Mead from the US, who said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has." This is the quote that inspires me for action, and I hope you will all join our team to make the world a better place, and we can do it together.
Thank you. Right on time. Perfect. Appreciate it. And I thank the audience.
Perfect. Absolutely to the second. Thank you, Naveen.
Thank you.
Thank you.
Bye-bye.